Hi, everyone. Happy Friday, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. We're excited to welcome Dr. Rico Short as our speaker today, as he will discuss current trends in endo with regards to digital technologies, innovations in instrumentation, and an interdisciplinary approach. Dr. Short is a clinical professor, board-certified endodontist, and owner of Apex Endodontics. Before we get started, we have a few reminders for you. At any point during today's webinar, we do encourage your participation. Please type any questions you might have into the Q&A section of your control panel, and we'll answer them live at the end of the presentation as we have time. And Henry Schein is not offering CE credit for viewing or attending today's presentation live or on demand. I know we're going to cover a lot of ground in the next hour, so with that, I will hand it over to Dr. Short.
Thank you. Thank you for that warm introduction. And thank you guys for your Friday today at 1 o'clock. You guys can be anywhere else, but you decide to tune in to listen to what I got to say about endodontics all around the world. I want to appreciate, and I thank you guys for that. Thank you, Henry Schein, for giving me the opportunity to talk about my passion, and that's endodontics. If you've been following me for some time, whether it's on social media, Facebook, Twitter, Instagram, I always do something called the short case of the day. And why do I do it? Is because I have passion in what I do. And I love endo, and I want to teach everybody around the world how to be better in endodontics. So when I kind of decided to roll out this topic, I was like, man, current trends in endo, man, that's so much material. So we've got a lot of material to cover today. I won't be able to get into the weeds of a lot of stuff that I want to get into, but I'm going to touch the surface. And if you can come away with one thing, just one thing that you learned differently, then that means this Friday was not wasted. So without further ado, let's just jump in on the webinar. So the title is Current Trends in Endo, Digital Technologies, Innovations in Instrumentation, and an Interdisciplinary Approach. Again, my name is Dr. Rico Short. I'm a board-certified endodontist. I'm also a fellow in International College of Dentists and also assistant clinical professor at the Dental College of Georgia in Augusta, Georgia. Little disclosure. Again, thank you for Henry Schein for sponsoring this webinar. I'm an independent speaker, and this material that's presented is not influenced by any dental company. So I really am passionate about the things that I use and why I use them, and I get an opportunity to share them with you today. I have opportunity to speak all around the world. I'll be glad when this COVID stuff is over, because I like to see you guys live and in person and have an interactive session. And so I miss that, and hopefully this COVID thing will blow over soon and I can get back out there and actually shake your hand and interact with you, because I miss that. But until then, we're going to rock and roll with the webinar. And this is just a little video about me. Some people know me, some people don't, but this is a little quick, I call it my Hollywood intro video. So check it out. So as you guys can tell, I'm pretty passionate about this stuff. Hence, I made that video. My practice is in Smyrna, Georgia. It's on the outskirts of Atlanta, about 15 minutes outside of the city. Right now, a lot is going on in Atlanta. In fact, the NBA All-Star game is here. So we got everybody's in town for this great event. I hope it's a great event and everybody stays safe. But I'm right on the outskirts of Atlanta, and it's been an awesome pleasure to be here. I've been in my own practice now for 17 years, and it's been great. And I continue to learn about all the new current technologies available in endodontics. So what are some of the course objectives today? I want you guys to understand the value of current digital technology in endodontics, learn new instrumentation techniques in modern endodontics, and also learn how to manage some complex cases in endodontics. And if you're not comfortable managing them, knowing when to refer is just as important. So this is my beautiful, beautiful wife in the middle, Angela, and my two beautiful girls, Ava and Jayla. I have two high schoolers now, and they are driving me nuts. So if anybody knows how to handle some high school girls, please let me know, because I think trying to raise them is harder than doing endo. People say, oh, it's so tough to get into an MB2. I think it's even tougher to have two beautiful teenage girls out there. So if anybody got any tips on that, please inbox me on that. So let's just jump right in. What's the standard of care of endodontics? You kind of hear this. What's the standard of care? But in endodontics, there's only really one standard of care, and that's the rubber dam. That is the only universal standard of care we have in endodontics, and the rubber dam is crucial. If you don't use the rubber dam, what if this is your case? Then your patient, once you open an abscessed tooth, they may actually swallow some eggs that's not done. Like this is like some non-scrambled eggs. So you don't want them to swallow that. And that's why you have a rubber dam there. But also too, when you have a case, just like I just showed you, you can't put a rubber dam, especially if you're going to do an IND. So this is the case that I was able to do an IND on this gentleman because he was very swollen. He was actually getting ready to have an episode of Ludwig's angina. So this is the case, obviously we can't put a rubber dam on. And so I did an IND on this gentleman. We got him feeling better and put him on some antibiotics. And we proceeded to do endodontic treatment on that lower first molar. So if you don't use the rubber dam, guess what can happen? This is a case in the Journal of American Dental Association in 2013, where a man, he won $675,000 after settlement because the dentist dropped a tool or barbed brooch down his throat because they did not use a rubber dam. And the rubber dam has been around for 150 years. It is the universal standard of care in endodontics. And studies show that less than 44% of GPs use a rubber dam 100% of the time. So you have to use that rubber dam if you are a GP, because you don't want to be trying to defend yourself in court with a lawsuit just in case, like this patient, swallowed a barbed brooch. You don't want to be on the other side of that trying to defend yourself and trying to say, okay, well, this is the reason why I didn't use the rubber dam. Also, too, patients can aspirate these files. This is a NiTi file in an esophagus that this patient had to have surgery to have it removed. So you may say, hey, this is an 04 or 06 taper. I don't think it matters. I mean, he swallowed this thing, and I think he got bigger problems to worry about what taper that was. So this is the AAE position statement on dental dams. Tooth isolation using a dental dam is the standard of care for non-surgical endodontic treatment. It minimizes the risk of contamination and aids in visualization, and also prevents the ingestion and aspiration of dental materials, including irrigants and instruments. So you have to make sure you use the rubber dam, because you may say, oh, I got a plan, but like Mike Tyson says, everybody has a plan until they get punched in the face, until you have that one incident where that patient swallows that file or that clamp or aspirates it, and then you're in trouble if you don't have that rubber dam. Especially, you have to make sure you have it documented as well, documented in your notes, and also have a radiograph with the rubber dam in place, just in case there's ever any litigation. You can have proof that you did use it. So let's jump here into diagnosis. So this patient was misdiagnosed for years because he actually thought he had a chronic sinus issue. I'm Dr.
Rico Short, board certified root canal specialist, and have a patient here that had some experience with some chronic sinusitis and some other issues, and he just want to tell you guys what happened in his experience before the root canal and after the root canal.
So you can check out the area of infection there, the sinus floor. And that's also on 14.
The sinus doctor had told me for years he thought that the source of my sinus infections was a infection in my root of my tooth. Took me years to believe him, and finally I did believe him. I came out to Dr. Short. He did the root canal, which I would avoided for at least 10 years. And almost instantaneously, the difficulty with my sinuses began to clear up. It's amazing. And I would have never believed it if it hadn't happened to me. I don't like operations. I don't like the word root canal. It scares the hell out of me. But it didn't hurt, and they got great TV.
Thank you. So as far as how root canals are done now, would you say it's something that's very scary like they used to be, or do you think, technology has made it a lot better?
Well, I don't know what it was like before because I never had one before, but this was nothing like, I don't know what I expected, but this was relatively easy. And everything was done on time. Everything, they told me what was going to happen, and everything happened just like it was supposed to. So I would not hesitate to have another root canal if I needed it.
So tell me a little bit about your sinus problem that you had. Did you ever have any sinus surgeries and things like that prior to the root canal? Or tell me a little bit about how your ENT kind of figured that, hey, you know what, this might be something different than just a sinus issue.
Well, I've been going to the same doctor for 20 years. I've had chronic sinusitis for 20 years. He wants to operate on me and open up the sinus because it apparently is not draining properly. But he also felt like there was some risk that all sinus problems that I've had related to this abscess or infection in the tooth, and that infection was spreading into my sinuses. I didn't understand that, but now I do. He was absolutely right. Had we done this 10 years ago, I would have saved myself a lot of discomfort and taking a whole lot of antibiotics that I didn't really need to take.
Awesome. And also, I know you mentioned that you went to a particular dentist who did some fancy 3D X-rays, and I think he probably did some cone beam tomography or CBCT, and he was able to kind of see some things that the other that you couldn't see on the traditional X-ray. Is that correct?
My regular dentist saw nothing. Dr. K has this high-powered X-ray system that is able to really look into the sinuses, and he forecasted everything that has happened. That is, the X-rays told him that I have a problem with my teeth. I needed the root canal, and it's based on his work, he thought it was highly probable that once we got the root canal done, the infection problem would begin to go away. It's not, I wouldn't say it's completely gone away, but the difference from before when I had the root canal is just night and day.
Okay. Well, thank you, Mr. H, for your time, and we definitely appreciate you. And I know this message is going to help a lot of other people that deal with chronic sinusitis and other issues. That a lot of issues that we have could be multidisciplinary. It may not just be a sinus issue, it may not just be a tooth issue, it could be a combination issue. So we appreciate your time and helping people out there. Take care. Thank you.
So we have something called maxillary sinusitis of endodontic origin, MSEO, and a lot of these cases get misdiagnosed, and patients have been on antibiotics for years and things like that, and it's an endodontic problem. But guess what? A lot of these you can't see on the 2D PA. So he actually got a 3D CBCT taken, and it was very obvious that he needed endo on both of those teeth. We did the endo on both of those teeth. And everything healed up, and he did really well. So, it's really, really important that whenever we're doing endodontic treatment, sometimes we have to, follow up with an ENT or follow up with other people. Even Shaq, heck, he might know what's going on. So this is a cool photo I got an opportunity to take with Shaq. This is pre-COVID with the NBA tip-off, and Shaq, he's a really, really, really cool guy. So diagnosis is the most important thing in endodontics, because if you don't, you'll be doing root canals on teeth that probably don't need them, and then turn around and do surgery like this particular case in Cohen's pathways of the pulp. This case got misdiagnosed, and the patient had underlying fibromyalgia and all kinds of other atypical facial pain, and they end up getting all this endodontic work and all these surgeries, and probably did not need many of them at all. So anytime we are having issues, when the patients come in, we have to understand what the diagnosis is and understand what the chief complaint. One of my good friends, Josh Powell, he's a 2-time NBA champion. And I say, man, how do you guys win these championships with with Kobe. And how'd you guys do that? He said, we had to diagnose the defense. So diagnosis is super, super important. And it starts off by listening to the patient, trying to figure out what the patient's chief complaint is. And then you put those subjective findings together with a diagnostic test. And then that's how you come up with the diagnosis. This patient came in and her chief complaint was that her front tooth was dark. She had a history of a trauma and she thought, well, maybe I can just bleach the tooth and it'll be fine. Well, we did pulp testing and the pulp ended up being necrotic. So we had to do endo, and I had to explain to her we had to do endo on the tooth, but we can internally bleach it. And so that's what we were able to do. So we did endo on this case and was able to internally bleach it. And everything went really well on her case. This is another case that was tricky to diagnose.
There is some periapical pathology going on. That looked kind of weird, so I decided to do a limited field of view 3D CBCT on this case. So this is the bone rendering here, 3D bone rendering from the buccal aspect. And on tooth number 15, which is here, everything looked pretty intact. But as we look at the palatal aspect, we can see that there is quite a bit of bone loss here on tooth number 15. And if you look very closely, you can see here she has a vertical root fracture that actually turned into a split tooth. You can see it right along here with the 3D bone rendering from the palatal aspect here.
So you can see that was a vertical, independent vertical root fracture that you could not see on the 2D CBCT. And this is the axial slice.
The axial slice. And we'll be able to also see the same thing here.
This is the coronal slice.
Coronal slice. Now, if this tooth was root filled with gutta percha and also had a post, you probably wouldn't be able to see this crack.
So if that tooth was root filled with gutta percha and had a post in it, this probably would not show up because you'll have what we call scatter radiation and all this artifact. You won't be able to see it as clear. So this is the case, tooth number 15. It looked pretty standard, nothing really surprising on the 2D PA. And then once we do the 3D, we can see, especially on the palatal root, all the bone breakdown, and we can see clearly, looking at the sagittal slice and the coronal slice, you can see the fracture there. And this tooth had to be extracted. So as dentists, we're living our best life. It's always cool to run into friends. This guy is a comedian, actor, and rapper. He's a one-hit wonder. He had a song called Smile, a lovely song. But don't listen to it around younger kids because there's some language in there. But it's a pretty cool song, I thought. So we're living our best life. So as dentists, we are living our best life, being able to help these patients. So what about pain control in endodontics? The Endodontist Colleagues of Excellence put out a really nice summary in the winter of 2015 as a 3D approach for treating acute pain. This is a case of mine, tooth number 30. This was a hot tooth, and this tooth actually had a micro crack in it. This patient was dying in pain, and you can't see micro cracks on the 2D, and you actually can't even see them on a 3D. You have to diagnose these, particularly using a tooth sleuth. That's the best way to diagnose this, and also using temperature sensitivity tests like Endo Ice. So I could not get this dude numb. I mean, I did everything. I did inferior alveolar nerve block. I did PDL, intraosseous, stable. Nothing worked. So I'm going to give you guys a little secret here. Put this in the back pocket. All right. I'm going to tell you guys one of my top secrets. Just because you spent an afternoon with me on a Friday. The Medrol dose pack plus nitrous oxide. So if you're not familiar with the Medrol dose pack, it's basically like a mild steroid, 4 milligrams. And I tell the patients the hot tooth, I say, hey, I want you to take this. They take 6 pills as a loading dose immediately and then follow the instructions on the packet. They do this for 5 days, actually 6 days, for a week. And then when they come back, I put the patient on some nitrous oxide. We'll be able to do the same thing, numb them up. In fact, you only really need to do an inferior alveolar nerve block and maybe some buccal and lingual infiltration, and that's it. You don't have to do the Stabodent or X-tip or intraosseous. And I can promise you, you're going to notice a world of difference when you're able to anesthetize these patients after you use the Medrol dose pack plus the nitrous oxide. So I was able to get it numb. I opened this tooth up. There were 3 distal canals and 2 mesial, so there's a total of 5 canals in this lower molar. Here it is. Those molars, the canals are filled. So you can see we had 3 in the distal and 2 in the mesial. And we had a nice result towards the end. So what are some tips for gaining effective anesthesia in that HOT lower molar? I already told you guys the Medrol dose pack is one way. But if you don't have that Medrol dose pack handy, you can do a PDL injection. You can do an intraosseous injection, but you don't use any epinephrine. And that's like an X-tip Stabident kind of thing. Buccal infiltration with 4% articaine. That enhances the efficacy of the block according to Hargreaves. So you can use those kind of things. So what about after endodontic therapy? Pain control. Right now, I don't really ever give narcotics anymore. Once I do endodontic treatment, I give them a combination of ibuprofen and acetaminophen, 600 milligrams of ibuprofen and 1 extra strength Tylenol or 500 milligrams of acetaminophen right after treatment. And I tell them to do that every 6 hours as they need it for pain. It's very rarely they ever call me back. Rarely they ever call me back. And some of the studies shown by McKay talks about this is actually more effective than narcotics. It produces a greater peak of analgesia and is more consistent analgesia. And guess what? You don't have the narcotic-like side effects. So if you have kids in the house, teenagers, guess what? They're not going to really think about getting high on ibuprofen and acetaminophen. But if they see some Vicodin and Tramadol and all those other kind of things, then you may have some issues on your hands. So this is very safe and is very effective. So what about our antibiotics update? This is a nice little type of update that the AE put out on antibiotics and when to use them. So when should I use antibiotics for odontogenic infection? So there's a few indications for them. Acute apical abscess in immunocompromised patients, acute apical abscess in immunocompromised patient when same visit treatment is not an option. So if you can't open the tooth up and drain or do an IND, then you want to give antibiotics. Also localized fluctuant swelling, acute abscess, if there's some systemic involvement, fever, malaise, progressive infections, rapid onset of swelling, cellulitis, osteomyelitis, or even persistent infections, chronic exudation, and it's not resolved by regular endodontic treatment and medications. So when not to prescribe antibiotics? You don't want to prescribe antibiotics with patients that have symptomatic irreversible pulpitis or symptomatic apical periodontitis, meaning that they have pain and percussion and biting. Antibiotics will not help them. If you have a necrotic pulp with a radiolucency, if they don't have any swelling, antibiotics will not help them. If they have a sinus tract, antibiotics is not recommended. If you have acute apical abscess in immunocompetent patients, but you can do the same visit and you can clean it out, put some antibiotics inside like calcium hydroxide, then they don't need antibiotics in those kind of situations as well. So what are the top antibiotics? Right now, the AEs are recommending PMVK and amoxicillin. That should be your first line of choice for antibiotics. And Segura talked about that in IEJ. The second line, if that's not working, is augmentin. That's right, amoxicillin and clavulanic acid. And these are effective for patients who continue to have unresolved issues, but you want to monitor these patients for some GI issues. Salvo talked about this in the Journal of Antimicrobial Chemotherapy in 2007. The third line is metronidazole and penicillin. This is a combo effect, but you don't want to use metronidazole or Flagyl by itself because it's not really effective for an odontogenic infection. It works better in conjunction with PMVK, but if they're allergic to penicillin, you can also add clindamycin to that. It provides an excellent gram-positive and gram-negative coverage. For penicillin, amoxicillin, and allergic patients, what do? We standardly would just jump to clindamycin. Now we are rolling that back. We're trying to hold clindamycin back because of the increased C. diff issues. So you don't want to use clindamycin now as a first line for PMVK and amoxicillin allergic patients. Again, it's issues with C. diff. You want to use a Z-Pak instead or azithromycin instead. And clindamycin, some people don't know this, but it has a black box warning. and you don't want to get people in trouble like I did. I actually had C. diff. I was on vacation in Dominican Republic and ate something bad, got some kind of bad infection, and they put me on all these antibiotics there. I didn't even know what the name of them were. Some of them, I was just trying to get some help. I got back here, and then they put me on amoxicillin. They put me on clindamycin. I was on clindamycin probably for almost like a month, and I got deathly ill. I was in the hospital, actually almost died. I ended up having C. diff. They had me on vancomycin, as you can see here, and also Norco and morphine. I was in the hospital for a little bit over a week. And by the grace of God, I was able to recover from that. So I have a personal, just experience with clindamycin, having C. diff. It can kill a patient. So do not use that clindamycin as your first choice. And I know we're used to doing that, but clindamycin, if a patient have had a history of C. diff, you can't even give them clindamycin because it can actually cause them to go back and have trouble and also can kill them. So make sure you're careful with the clindamycin. This is a cool picture here. Me and Khalid, a music artist. I got a chance to take my daughters to see this cool concert in Atlanta. This is prior to COVID. Those are my two daughters right here having a good time. So anyway, let's move on. Let's go to diagnosis. Who's reading the x-ray? So this, the classic study by Mayo Goldman, and it can be very subjective. Some people say, yeah, that's pathology. Maybe it's not. They did a study and there was only a 50% agreement among interpreters for the radiographic appearance of pathosis. And when these same evaluators looked at their initial evaluation, they agreed less than 85% of the time. So it's very, very subjective when we are reading these radiographs. And then I have an arrow pointed that. What is that? That's actually, there's a nutrient canal in this area. So this case had periapical cemental dysplasia, and it's a condition where you have fibroosseous proliferations that replace the bone and PDL of one or more teeth. Oftentimes, these can be cases where you want to jump in and do endo because you think there's an infection there, but do not. You want to make sure you pulp test these teeth because if they're vital, chances are it's periapical cemental dysplasia. But that little black area is actually a nutrient canal. So what are some of the key features of PCD? Black females and greater than 75% of the cases, middle age. Mandibular incisors, they can be found in maxillary teeth and molars as well. But most of the time, mandibular incisors, their stage development, like I said, most of the teeth are vital. So if you pulp test those with cold, they feel cold. You pulp test it with the electric pulp tester. Do not do the endo. If you're really concerned, you can always send it to an oral surgeon for a biopsy just to make sure there's nothing going on. But Ackerman does a great job back in 1992 where he talked about key features of PCD. And also you won't usually find these lesions with caries there present. This is a cool picture with Dominique Wilkins, the human highlight film. You guys probably, I don't know, you guys may not be old enough to remember him, but he's an Atlanta legend. I got a chance to meet him and talk to him and checked out a few of his highlights.
Dominique. Unbelievable. Lewis couldn't get anywhere with Terrence. Dominique fires outside, goes after it. Whoa! Well, Kevin McHale made a classic mistake. The Celtics, if they've got a big man out on the defense.
So make sure you diagnose properly so that you'll be considered a human highlight film in dentistry. So what about cervical resorption? We talk a little bit about that. This can be confusing because it almost looks like caries on an x-ray. So this is a picture showing traditional x-ray versus a CBCT. Consolaro talks about this, that on external cervical resorption or any kind of resorptive defects, you really need to do a cone beam on those so you can see the extent of the lesion to see how you should treat it or if it can be treated. This is a case of external cervical resorption here on tooth number 9. So this, as you can see, there's no caries. This was probably dealing with some kind of trauma, maybe ortho, or maybe some type of physical trauma that that patient had. Consolaro also talked about external cervical resorption. What's the pathological approach? So the predentin and the remaining mineralized dentin are preserved. So these pathological conditions do not go into the pulp. They actually stop right before it goes into the pulp there. So these, in my opinion, are more periodontal issues because usually the pulp remains vital and asymptomatic. So these clastic cells do not get attached to non-mineralized tissue. So this is a case, an 11-year-old female came. She did have pain. She had history of stage 1 ortho. You can see the external cervical resorption on that distal area. So again, this is not decay. You'll see a honeycomb mixed radiolucent radiopaque area. You won't get a certain stick with the Explorer. The Explorer will actually kind of go through there and it would be a lot of bleeding there. So again, I talked about the 2 most common causes of ECR, trauma and orthodontics. And the pulp is usually normal on these kind of cases. So what kind of treatment? There's a surgical approach. We can flap it, lightly curettage the area, treat it with tricyclic acid and restore it with Gerastore. And then that's it. And we don't necessarily have to do endo on most of these cases unless the patient becomes symptomatic. On this case, the mom did not want to do surgery, and it would have been difficult to do surgery anyway. So we did the endo, and we packed up that defect with MTA and bioceramic sealer. Why do we do that? Because MTA has a high pH, and it's known to slow down the resorptive process and to try to maintain and help this patient keep this tooth as long as possible. So the prognosis could be guarded long term, but as long as we can keep this tooth, the longer we can keep this tooth in form and function, the better. This was a case of external cervical resorption on tooth number 14 that I treated. In fact, this was the husband of a referring dentist. He had a lot of pain on tooth number 14. And you can see that he has a lesion right on that distal palatal area. And this is before I had a CBCT. This was like 11 years ago. I didn't have a CBCT, or else I definitely would have took a CBCT on this case. We did the endo and we packed that area with MTA. This is a 10-year recall, and that MTA did not wash out because MTA is normally used for subcrestal issues, not above the bone. But in this case, that MTA is still holding steady, and this guy still have that same tooth. Everything looked great. This is 10 years. So this is a picture with Clyde the Guy Drexler, another famous NBA player, and an awesome athlete, and an amazing dunker. So let's go to CBCT in endodontics here. In 2018, Dentistry Today, I wrote an article that talked about my viewpoint on CBCT and endodontics, and is it the standard of care? Again, I mentioned there's only one standard of care right now in endo, and that's the rubber dam. So the CBCT is not the standard of care. Now, if you don't have a CBCT, you need to have access to one. You know, if you get an issue in court or something like that, they may pull out the locality rule. Basically, the dentist will be held to the same standard of the dentist practicing in the local community. And so you want to make sure you have access to one, even if you don't have one on your own, and be able to refer the patient out if you think they need one. This was informed consent by an attorney, Arthur Curley, in Dental Economics in 2016. It has to be documented if they do a CBCT, informed consent, and also informed refusal. They decide not to get the CBCT and it becomes a problem. They say, hey, doctor, you didn't give me the option, and then you won't be held liable. So you have to make sure you have informed consent if they do it, and informed consent if they refuse to do it, and write that in your chart, because you can be sued for not ordering the CBCT if it can prevent injury. So one thing about the CBCT as well is, it actually has more radiation than 2D. The studies show that 3D CBCT is 15 to 140 times the radiation than 2D X-rays. Now, that doesn't mean that you don't use it. It means that you just want to use it with discretion and as the ALARA principle, as low as reasonably accepted. So you want to make sure that you use the CBCT, but use it very prudently. And also the studies by Yeps talks about that the CBCT, the dosage differences in children are more. I mean, they receive 1 to 3 times as more radiation for the same area as adults. So in children, you have to really be careful using the CBCT because you don't want to expose them to unnecessary radiation. But CBCT is great in diagnosing and treatment planning. This is a case that I did dealing with the trauma. We'll talk a little bit about it more later if we get time, but it's very predictable in locating anatomical landmarks. But the 3D CBCT should not be seen as a replacement for conventional 2D radiography, but it should be used as an adjunct. And Hargreaves talked about that in Pathways of the Pope as well. So these are some images as well. This patient had some indiscriminate pain on those lower molars. And on the 2D, you can see that the endo looks pretty good. There's no lesion, but when you look at the 3D, you can see that there's a lesion on that mesial root. So we can see here that the 3D CBCT is very helpful in helping us to diagnose some of these cases that have atypical facial pain. And Patel, he actually talked about this as well, that he detected PAPs in only 20% of cases using 2D, but up to 48% detection using 3D. So again, like I said before, it's really good for patients that have atypical facial pain. So this is that case that I was showing you earlier, what CBCT really, really helped me diagnose and treat this case here.
This kid was 8 years old. He had a trauma, but he didn't have any pain. So the mom delayed taking him to the dentist until later he ended up getting a bump or a sinus tract on tooth number 8 here. So this is the pre-op of that area. This is tooth number 8 and tooth number 9. You can see the calcifications in tooth number 9. So we decided to do a limited field of view 3D CBCT here. And you can see tooth number 8. You see that defect here with the periapical radiolucency on tooth number 8. And as we spin it around here, you can actually see the defect is through and through all the way to the palatal aspect. So on this particular case, what we decided to do was endodontic therapy on this tooth on both teeth.
While I presented this.
And this is tooth number 8 here from the coronal slice. And you can see the calcifications here on tooth number 9. And also from the sagittal area, this is tooth number 8 here. And as we move over here, we'll be able to see the sagittal aspect here of tooth number 9. And you can see the calcifications here. So we did the treatment and we used bioceramic sealer and bioceramic putty on this case. And we ended up getting a really nice result here on tooth number 8 and tooth number 9. We brought the patient back. The sinus tract has resolved. And again, this was done with bioceramic putty. And this one was done with gutta percha and bioceramic sealer. And also we used some putty for this defect here. And we're going to see this patient back in another 6 months just to evaluate osteoporosis.
So we're going to bring that patient back in 6 months to make sure that everything healed and that patient is asymptomatic so far, and he's doing great. And hopefully we can keep these teeth for a long time. And I told the mom, if we can keep these teeth until he turns 21 and he needs implants up there, we've done him a great service. So I think it's going to be just fine. So we take the CBCT, have 3 different views: an axial slice, coronal slice, and sagittal slice. And if you have a CBCT unit, and if you're evaluating a tooth, especially in endodontist, you want to be able to evaluate that tooth in all 3 planes. It's very important. Some of the new stuff, Ackerman and Aguilera talked about. Now we have some surgical guides in endodontics. That way we don't have to freehand our apical surgery. So we can actually do surgical guides, and we can be more precise when we're doing apicals. We know exactly where we're cutting, and we know exactly where we are removing the root and also doing our retro prep. So this is some new stuff that we have in endodontics just to increase our accuracy and precision, and also reduce the intraoperative time as well, because we're not removing bone unnecessarily. So CBCT and detection of cracked roots. Sometimes you can see it and sometimes you can't. This is a patient that had some vague pain on tooth number 30, did a CBCT. You can see there's some buccal bone breakdown. And then really the main way you can see it is you have to flap it. And if it's very small, you won't be able to see it, like I said, on the 3D CBCT, especially if it's a root filled tooth and has a post like this one. It'll be very difficult to see the actual fracture. You have to do a surgical exploratory surgery and move it and clean it all out. And then you can see the fracture in most cases if it's there. And then that tooth would have to usually be extracted. Some of the advantages of CBCT and root fractures, if it's not root filled, Tyler talked about it's a very good adjunct if it's not filled with gutta percha or post. If the root canal itself is filled, it's going to be very difficult due to the scatter radiation that's going to keep you from being able to see exactly where the fracture is. And Ozer in the JOE 2010 says the fracture has to be at least a size 10 or 20 file to be seen on a CBCT. So you won't see those micro fractures on a CBCT. So you can not spend a whole lot of time looking for those. Again, you have image artifacts, like I mentioned before, that can hinder vertical root fracture detection. And Chang talked about that it's insufficient evidence to suggest that CBCT is a reliable test in detecting vertical root fractures in endodontically treated teeth. Now, it's not saying that you can't see them, but it can make it very, very difficult. He talked about this in a systematic review in the JOE in 2016. Walton talked about it as well. CBCT is unreliable for detecting vertical root fractures, and you guys know that's our Achilles heel. And when you have a vertical root fracture, the tooth has to be extracted, and maybe this will be changing. They got some new technology that are able to kind of reduce the image artifact that's coming through the pipeline, and maybe that'll change and we'll be able to see more detail in the near future. So if it has a vertical root fracture, the tooth gotta go. Peace out. Another study, I saw this. This is a cool recent study by Davis and Sharif in 2019, talked about the success of endodontically treated teeth that has a crack. And if you do a radicular extension, basically you remove some of the gutta percha where the crack is, and you put a composite core in there. Some of the studies show that these teeth are just as successful 2 to 4 years after treatment if you use a radicular extension, kind of like the old school amalgam core that Arun Nayar talked about. But a composite, if you have those and then you crown the tooth, they talked about the success is even higher. It's not a guarantee. You want to let the patient know, hey, you have a cracked tooth. We're doing everything we can to try to keep this tooth for you. And hopefully we can keep it for a long time. So the CBCT will not show lateral canals. Everybody's into lateral canals and puffs and things like that. Salsa talked about that you will not be able to see those on the 3D CBCT. So if you're looking for those, then you're wasting your time. Unless they're huge lateral canals, you may be able to see them. Do lateral canals matter? Domenico Riccucci did a nice study, talked about the fate of the lateral canals. He sectioned 493 teeth. He saw lateral canals present in 75% or more of these teeth. And Endo only partially removed necrotic tissue in the lateral canal. So we won't be able to remove all the tissue in the lateral canals. They also found that there's vital tissue in the lateral canals, and they were not removed. But these cases still look good, and they still heal without popping lateral canals, without puffs. I'm not a big fan of puffs. I think that the puffs, well, it's not that thing. Histologically, the puff shows that the body has to work harder. They create chronic inflammatory response. Now, the area will heal, and we like to see it. It looks aesthetically pleasing on the x-ray, but at the end of the day, that's putting the body more work to allow that area to heal up. So this is a case that I did on tooth number 18. We retreated this case, and there is a periapical pathology in the furcation. We did not pop a lateral canal, but that patient, the case healed up in 6 months very well. The 3D CBCT will not show you where the true apex is located as well, especially if you have a resorptive case. You won't be able to see that, or it won't show you where the apical constriction is. That's why you would need an apex locator, which I won't have a lot of time to talk about that, but the apex locator typically will locate where the apical constriction is, and that's the optimal terminus to end your root canal instrumentation and filling there. And sometimes you'll have a case where there's no apical constriction, and this is a nice slide by Dr. Balajano in Mexico there. Again, most of you guys know I treat a lot of celebrities that come in town. Sometimes you have to go and take care of them. Me and my wife help her.
They saved me. She was the best patient.
The best
so
patient.
easy.
Yep. Oh, so easy, so sweet, so kind. So we had a great time.
Thanks, guys.
So now Instagram famous, helping Miss Lala Anthony with her root canal. Surgical treatment planning with CBCT. It allows us to map out the inferior alveolar nerve bundle. So if you got to do surgery, you'll know exactly where it is. That way you won't harm the CBCT. Fayed and Johnson talked about that in JOE in 2014. Estrella talked about CBCT detects root resorptions. So internal root resorptions was detected in only 68% of the PAs, but 100% of the CBCT. So if there's any root resorptive issues, you want to make sure, like I said before, you get a CBCT on it. We talked a little bit about beam hardening. That could prevent you from being able to see, what's going on in root-filled teeth. Hope did a study. I thought this was pretty interesting when on CBCT, 2 teeth, vital teeth had radiolucency. So you have to really, really be careful when you're looking at the CBCT and don't just jump to conclusions. A healthy pulp rules out endodontic treatment. So let's talk about the surgical microscope. So we know the dental microscope isn't a new concept. It's been around since 1907. I use a surgical microscope on all my cases. Which one is the best one? It's the best one that works well in your hand. Even if you don't have a surgical microscope, I think if you got some really good loops and some illumination, you should be fine. Microscopes, endodontists, most of all endodontists use microscopes now, but believe it or not, microscopes is still not the standard of care.
Yeah,
this is me using a microscope.
Pressure here.
Pexogenesis on this kid. And it's going to be crucial for you to be able to see what's going on if you're doing a pexogenesis. And this is what it looks like under the microscope when you got some healthy pulp. And this is me about to put the MTA on top of the pulp for a pexogenesis on this case here. So we did a pexogenesis on this case, and we brought that patient back in 2 years without having to do the endo. We can see the end of the root closed very well. Dental microscope is also good for non-surgical procedures, being able to see if there's recurrent decay, checking crown margins. Also, it helps you to see if there's any cracks present. Also, it helps you to see if there's any missed canal. This is a case where a dentist did endo, they missed a couple of canals, and I was able to use the microscope to find the other 2 canals in his upper premolar. Retreatments, studies by Balderassi talked about retreatments. Surgical microscopes help us find canals, help us remove silver points and other carrier-based material like silver points and other things like that. This is a case where I was able to use the microscope to help me remove the silver points and retreat this case here. And we had a really nice result after 5 years, nice healing here. This is another case. We did a retreatment here. I used ultrasonics to remove this post, and it takes some time, and the microscope helps us, but we're able to take that post out, and we're able to retreat this case. We placed calcium hydroxide. We obturated this case with MTA, and we had a nice 1 year healing on this case. So the dental microscope also helps us with perforation repair. Krupp talked about that. Allows us to be able to see where the perforation is so we can pack it with MTA. This is a tooth that I was able to retreat. It had a perforation. We packed it with MTA, and we used gutta percha as well. We brought the patient back in 6 months and then a year, and it showed some nice healing. So this patient did not have to get an implant. We were able to successfully retreat that using the microscope. Also, the microscope helps us in removing separated files. This is a file that's separated. Here, we're able to remove that file find another canal, and obturate the case. Again, microscopes and surgical endodontics. Kratchman Kim talks about this. This is the case that I did, the endo. This is a pre-op. We had a lesion here. We retreated with calcium hydroxide. We brought the patient back. Everything was good. 6 months, the mesial root started failing. The distal root was fine. We had to end up doing surgery after 3 years. We did the surgery. There was an isthmus there. We did an apical. And in 6 months, the area healed up well. And this is the before and after 4 years. So be a boss, use the microscope. And if you don't have a microscope, you make sure you have some high power magnification and illumination. So what about managing the open apex? Apexogenesis, we talked a little bit about that. I had a cover article in 2013. Apexogenesis, the pulp has to be vital. And this is the case that I showed you earlier where I used MTA and we're able to take care of this case. Apexification, we don't really do this much more now that we have all the new bioceramic materials. But apexification, the pulp must be necrotic and open. This is a trauma on this kid on 8 and 9. So we did endodontic treatment on tooth number 8. We packed calcium hydroxide. We had to wait 6 months for an apical barrier to form. And then we obturated the case, but there's no root development. So we did get the case to close, but there's no root development. So that's a drawback from apexification. So we don't do that as much anymore. Now we can do immediate apexification. You had a case like this, a previous root canal had a surgery on it. Again, we used a microscope and we're able to clean everything out. And we used a map system to be able to place the MTA directly at the apex, and case is done. The patient went back to their general dentist to get a post and core and build up in the crown. And that case was able to be salvaged. I don't have a lot of time to go into my book, but anyway, you follow me on social media and you'll learn about my tragic eye injury that happened last year. But by the grace of God, I got surgery and being able to go back and do what I love. So let's talk a little bit about regenerative endodontics. I wrote an article, continuing education article on this in Dentistry Today. On this case, the apex have to be immature with a necrotic pulp. This is a case on the lower premolar. We use the patient's own stem cells to promote healing here. And they're there at Hertwig's epithelial root sheath. So this was a dens and vaginitis case. The pulp became necrotic, replaced calcium hydroxide. In 1 month, we completed it with MTA. And in 1 year, we can see the apex closed. And it's amazing stuff that we can do. And some of the studies show that the pulp still remains vital. However, with MTA, we see staining. So now we use bioceramic material, bioceramic putty, and we use the same technique. And the difference is that we don't have to worry about staining. This is a 2-year recall on a different case, but we don't have the staining here. So what about endodontic retreatment? Endodontic retreatment, endodontic treatment is still successful, over 94% survival rate. And sometimes it's not. That was a case that I did. Everything looked good. We retreated the case 2 years later. Boom, you got a vertical root fracture and the tooth had to be extracted. So even though that's the case, 96% of the endodontic cases that are done are successful as long as it can be restored. And it's really hard to compare endo versus implant because you got one that's naturally made and the other one is man-made. So both have similar failure rates. But these are some new studies that's coming out about implant failure that can occur later on if a patient has been placed on bisphosphonate therapy. That's an issue. ProGrow talked about that. And so we have to be careful not just going straight to an implant. We have to look at what are the ways that we can save these teeth. This is a case, tooth number 20. It's been there for over 20 years, and I consider this being a success because it's been there over 20 years, and this patient did not want me to touch that case. This is a case where the implant was in danger due to the infection to the tooth next to it. We were able to do the endodontic treatment, we placed calcium hydroxide. We finished the case in 6 months. We see some nice healing. The implant is safe. There's some new research that talks about implant failure with antidepressants. Some of the studies show that the antidepressants can actually cause implant failure in the future. So we really got to be careful with these patients on antidepressants. We're going to talk a little bit about bioceramic sealer and bioceramic gutta percha. That's the new stuff that we're using now, bioceramic technology. It's great stuff. Domenico Riccucci talked about this in 2019. This is a nice histology, and it shows that these are some great tools that we can use at our disposal now versus the traditional sealer and traditional MTA. This is a case of premolar that had a previous root canal and a post I was able to treat. We retreated this case. We used a bioceramic cone and some bioceramic sealer. In 6 months, we got some nice results here, and everything healed well without doing surgery. Some of the studies by Osiri talked about that bioceramic cone with bioceramic gutta percha can actually increase the strength of the root. So that's some cool technology and something else you can think about if you want to try to increase the strength of the root after endodontic treatment. And also you can use a fiber post as well. So what about some of the new instrument technology? We have some heat-treated NiTi files. There's so many. Everybody's in the game on that. Also, we have new non-instrumentation technology by San Endo called GentleWave. You guys probably heard a lot about that out there. But at the end of the day, is there a really difference between all this technology? You know, is the clinical evidence relevant? And everything that I read out there, it talks about there's not that much difference with using all these different files and different systems if they're used properly. So no matter what you use, if you understand, you know, the material, you understand the biological properties of what you're trying to do, you're still going to get a successful outcome. Now, they can help us a lot too, because this is a case that I was able to do. Look at the curve on this molar. I mean, there's no way I could have used traditional nickel titanium file. They would have separated. But with the new technology with heat-treated NiTis, you get the flexibility and the strength, you know, as well with these. What about endodontic size? And people talk about, oh, how big do the access has to be? Everybody's jumping into this conservative, minimum invasive access. And I agree that you want to try to keep things as small as possible, but you need to still see what you're doing. I like this study by Platino. He talks about that teeth with traditional endodontic cavity showed lower strength than the other groups. So you don't want to open it up wide, that's in A. You want to try to be around B, which is a conservative cavity. You don't have to be with C where it's a ninja access and you can't even see what you're doing. And if you're going to get a crown, the studies show that it doesn't even matter if you're going to place a crown. Now, what about if you're trying to find your canals? Well, the studies show that the ninja accesses, the small, tiny accesses, canal transportation was significantly higher. And you don't want to do that because that can cause the case to fail, as studies by Rover. You have to open it up wide enough so you can see what you need to see. This is the case that I did. This premolar, it had 4 canals. There's no way I was going to be able to find all 4 of those canals with the small ninja type of access. And there's also some studies that show that the fracture resistance, and there's no difference when you look at traditional access versus conservative access using composite material restoration. There's no difference in the fracture resistance in there. So, you know, when you start trying to do all these other things, you have to make sure you know the research about it. So you don't have to do the truss access or ninja access for your case to be successful. And again, Haposalo, he talks about this new technology, non-instrument technology, irrigation using San Endo and minimum invasive endodontics. And the studies that I read, that it is an acceptable technique, but there's no significant difference in outcomes with this new technology. So if you're using it and if you enjoy it, fine, but there's no significant difference in outcomes that we've seen using this minimum invasive endodontic approach or even this San Endo. So most of the studies show that, like I said, it's an acceptable technique, but most studies are in vitro and not in vivo, and case selection is very critical. You can't use this type of device on all cases. So I'm ending it up here. This is the TikTok that my kids made me do. This is the endo slide. I'm gonna show you how to go right foot up, left foot slide, left foot up, right foot slide. Basically, I'm saying either way we about to slide. Hey, we're killing this one slide. Don't you wanna dance with me? No, I could dance like Microscope. Son, I could give you the. All right. So hope you guys learned something today. Thank you for your time. If you want to follow me, you can follow me on Twitter. I'm on Instagram. I'm on Facebook. I'm kind of everywhere. So thank you guys for your time. So now I'm going to entertain any questions that you may have.
Awesome. Thank you. We've got a couple questions here. The one that came in earlier was, what is your most preferred method for internal bleach?
Oh man, I got to charge a higher fee for that, man. That's my specialty. So what I like is I use a combination of sodium perborate and superoxide, and I mix them together into like a wet sand-like consistency, and I place it in the tooth, and I close it up with Cavit, and I bring the patient back in a week. And usually it's a very nice result with that. And that's my go-to. And I've been using that for, I don't know, almost 20 years, and it works really well.
Not all of us have a CBCT. What other modalities can we use if the 2D X-ray does not give more information?
Well, you can use, I call them off-angle film, because I didn't have a CBCT for years. In fact, I was one of the late ones to get into the CBCT arena. Just because of the expense. And I have people follow me around the world, and it's expensive, it's expensive in the United States to get one, more so in other places where finances are tight. I would recommend doing off-angle x-rays, and hopefully you can find what you need to find in those. But unfortunately, the CBCT is just gonna show you a lot more information, and especially on internal resorptive cases or external cervical resorptive cases, it's kind of indispensable. You won't be able to see a lot of that information with just 2D radiography.
Getting a lot of props for that TikTok video, so you might have a second career there. Let's see. Is MSEO linked to normal physiology of the pulp in communication with the maxillary sinus, or is it pathology of the pulp in communication with the sinus?
MSEO is basically the pathology of the pulp. That's what creates the maxillary sinusitis of endodontic origin, MSEO. So usually that's where it comes from. And then what happens is it interacts with the sinus, and you can see this, a lot on the CBCT. You'll see that the sinus is filled with fluid on these cases. And once you do the endo on these cases, I mean, it's just amazing how the sinus issues resolve on these patients. I mean, so it's definitely it's a sinus response to a pulpal problem.
Has utilizing MTA ever resulted in an ankylosis of consequence in any of the cases you've treated or on cases on which you have consulted?
No, the MTA that I've been using MTA for over 25 years, and I can't recall the case when you have that. Now, in some trauma cases, you're going to have that just because it's a trauma. But the whole purpose of the MTA is to reduce the osteoclast and reduce the resorption in that area so that you don't get that. That's the whole point, or one of the points using the MTA, so that you still can have the periodontal ligament. So if the patient ever needs ortho, they can still get that with a case that had been treated with MTA. So, I'm not going to say it never happens, but it's rare.
Can you please talk about how to fill canal with calcium hydroxide and how to clean it?
So what I like to do with calcium hydroxide depends on the case. It comes in two forms. There's a paste form where you can inject it, but you got to be very careful because you don't want to get a lot of calcium hydroxide out of the apex because it necrotizes tissue, vital tissue as well. So you can get something called a calcium hydroxide burn, and it can necrotize the tissue outside the apex. So you want to be very careful and try to keep the calcium hydroxide inside. So there's a paste form and there's a form that you can mix yourself that comes in a powder, and you can mix it in a case that if you have a wide open apex, like the case I was showing you with like, apexification or something like that, you want to mix that, because if you squirt that in the canal space, it's still going to go everywhere because there's no apical stop. So with those, I would mix it and then dry it pretty well and use an amalgam carrier to put it in there. And then I would use my plugger and measure my pluggers so I don't push it out the apex.
Any thoughts on using lasers in endodontics?
Yeah, so, lasers have been around for a while, and lasers have creeped in endodontics. But the problem with lasers is that, the light doesn't go around a corner. And so we know canals aren't straight. They have curves in it. So the laser diode can't go around a corner. Therefore, it can't disinfect around curves. And also, too, if you turn a laser up, because some of the studies show that maybe we can obliterate the canals with the laser, the thing is you don't have total control over the laser. So you don't know how far that this laser is going to penetrate. So that's been an issue with lasers, but I have seen lasers used to disinfect certain canals and fit straight. And I've seen there's some good studies with that. But as far as using it exclusively in endodontics, I don't think it's a really, something that I would use in everyday endodontics.
What do you recommend for post-operative symptoms after endo? Some patients are sensitive for a few days to weeks. Is that what you typically see?
Yeah, so post-op sensitivity with endo, you're going to have a lot of that. First of all, after every patient, this is another key. This is another jewel. This is another diamond I'm throwing. Make sure you reduce the occlusion. Make sure that if you reduce the occlusion, the chances of them having post-operative sensitivity is going to be minimal. So make sure you reduce the occlusion, almost take it out of occlusion if you can. Also, too, I alluded in one of my slides about giving the patients the combination of 600 milligrams of ibuprofen and one extra Tylenol or 500 milligrams of acetaminophen right after treatment. And that's really going to help. So when the anesthetic wears down, and then that analgesia would already be peaked, and so that they won't have such a drop-off with post-op sensitivity. So those two things, if you do those, you'll realize that you're going to have less post-operative discomfort for your patients.
All right. And then our last question for the day is, how do you effectively test posterior teeth for vitality?
Typically, I would use, if they have a crown on the tooth, I like endo ice. That's my go-to. And if my endo ice is kind of like, I'm not sure. And then if it doesn't have a crown, I'll use the electric pulp tester. So that tests the vitality of the pulp. And I didn't have a lot of time to go into that. But I do have a whole presentation on diagnosis and how to use these kind of things. And also, too, you can also use, if you suspect that there's a necrotic pulp, you can use what I call a warm water bath. You can put a rubber dam around the offending tooth, and you can squirt some warm water around it. And if they say, oh my God, this is hurting, chances are you got a necrotic pulp, and that's the offending tooth that you need to do the endo on.
Excellent. Well, thank you, Dr. Short, for your time today. Appreciate the energy and passion. If anyone has additional questions about today's topic, please feel free to email us at webinars@henryschein.com, or feel free to connect with Dr. Short via email or through social media. Additionally, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. As a thank you for attending today, everyone will receive this recording via email sometime in the next week. Thank you all for joining. We look forward to seeing you back here in future webinars, and have a great weekend.
Thank you.